All right. What I'd like to share with you next is just my experience with sinonasal and skull-based tumors, benign and malignant, which the experience is now, I think it's about 420 cases or so, patients that I've managed. As you'll see, I'll show the numbers. The reality is with these complex diseases, you may not be doing the one and only operation. So there are some patients who had one or two or more surgeries for that matter. And I'll also try to highlight just some of the things that I've learned from my own mistakes as well. These are the disclosures. When we look at innovation, it can either be evolutionary, which is a natural extension of the things that we already have. So you go from, an iPhone 5 to an iPhone 6, it's kind of evolutionary. But there are things that are what we consider disruptive innovations. And there's no question that we look at the endoscope as we utilize it in our practice today, this truly was a disruptive innovation. It truly changed the paradigm in how we manage sinonasal and skull-based problems. And there's a picture of Howard Hopkins, who was really the pioneer of modern surgical optics and should be credited for this idea of the rod lens system. And he basically turned this upside down. These were the original telescopes, which were these little tiny lenses interspersed between air, but then he actually turned the paradigm upside down. So you have these actual glass, quote unquote, you have these air lenses that are interspersed with glass. And what that did is gave us a wider viewing angle, improved color and resolution, and much greater light transmission, and really is the precursor to the rigid endoscopes that we use today. Concurrently, you have this concept, the Messerklinger concept, the concept that the mucociliary flow that actually happens in our sinuses, it's not just some random phenomena. It's coordinated and it's directional. And that truly changes the way we think of sinonasal physiology and how we think about sinus disease, that there are transition spaces, there are subordinate sinuses. So this results in codification of the concept of endoscopic sinus surgery. If you haven't, I would encourage you to read these two Sentinel papers. They're absolutely worth your time going back to those original papers. And so the idea of establishing ventilation and drainage and removing disease tissue using the rigid endoscope as your primary surgical modality, and then being able to accomplish this with really minimal morbidity and bleeding. So as I look at the evolution of the paradigm now to endoscopic tumor surgery, whether they're sinonasal or skull base or beyond that, these are really the key innovations as we look at them. Clearly, the endoscope is key, but really the refinement that's happened with surgical instrumentation, microdebriders, drills. Most of you probably have your own favorite cautery device, and also the introduction of surgical navigation, I think, is critical to the endoscopic tumor paradigm. We've really gone beyond the original iterations of endoscopy. We have high definition endoscopy, and actually there are now software modifications that can really mag up the illumination further. You can highlight contrast much more greatly, especially looking at vessels along the dura or into the pterygomaxillary fossa. And there is 3D endoscopy available now as well. I've looked at all the versions of it. We wrote a paper on it a few years ago on one of the early versions of that. To this date, I'm not able to tell you that it's far superior than the high-def 2D endoscopes that we have available, especially with the current software modifications. Image-guided surgery is critical to this paradigm. It's most important, frankly, for pre-procedure tumor planning, and then really your intraoperative navigation is just following those steps that you've outlined prior to the surgery, and this helps you create a 3D tumor map. And then there's software modifications where you can do a CT angio protocol or CT MR fusion, taking advantage of the bony and the soft tissue definition. I think the most critical aspect of this is a graduated surgical experience. You know, I have trained about 8 fellows to date, and I always tell them, you have to be a really good sinus surgeon before you can be a really good tumor surgeon, and that's an absolute prerequisite. Not everybody who does a fellowship or has done otolaryngology training will always get to this, and that isn't necessary. We don't need everybody to be able to take out clival tumors, but if one is aspiring to get to that, it is clearly a stepwise graduated approach, working through a variety of these things, but clearly, you know, management and being facile in inflammatory disease is a key prerequisite before you advance to the more complex cases. So being good at primary revision surgery, mucoceles, I think managing complex frontal disease. For a lot of these tumor cases, I often do Lothrops, and those Lothrops are actually relatively straightforward in tumor surgery, but I can tell you this is a patient who's was sent to me from Austin a few years ago, who basically had a massive, motorcycle accident, forehead crunch, and had a bunch of bone chips and other things placed up in his frontal sinus. That's a patient many years ago, probably would have needed a revision osteoplastic flap, but we were able to do a drill out and essentially take out all of those partitions. That took me several hours, but he was able to go home the next morning, and he was not interested in having his forehead open again for the third time. As we've heard earlier, expertise in CSF leaks is critical, and really being able to manage this for a broad variety of pathologies, whether it's traumatic, iatrogenic, spontaneous. We can now do this reliably with good results. I think, as Chris was talking about earlier, I think managing orbital pathology is really key as well. You can't be scared of the orbital interface. If you're going to do tumor surgery there, you're likely to leave a bunch of stuff behind. So being able to do DCRs, orbital decompressions, optic nerve decompressions, really being comfortable managing the entire orbital interface from the lacrimal system to the optic nerve and any challenge that lies therein from those two landmarks. I think before you progress to malignancy, managing benign tumors is critical, whether it's inverted papilloma, fibroosseous lesions, JNAs, pituitary tumors. These really form the foundation of endoscopic tumor surgery. Showing you an example of a sphenoid inverted papilloma, massive tumor, as you can see here, erosion over both the optic nerves, over both of the carotids. This is the lesion right here. Here's the carotid arteries. This was a staged tumor, and there's nothing wrong with that. I took out probably 80–90% of it the first time. This was not a peek and shriek. It was a judgment call, knowing that this is benign pathology, and I would come back a few weeks later. She was an elderly lady. I actually talked her into, you know what, there's a little bit of tumor there. I can see it. Let's just watch. She said, I want this whole thing gone. I want to live to be 100. I said, fine, we'll go back. Original pathology, benign IP. My surgery, benign IP. Took her back, took out the last little bit of component. There was squamous cell carcinoma arising within that. And you can see this is pulling the bone over the right paraclival carotid. These are just one of the sphenoid partitions that was essentially plastered on there. She did go on to receive postoperative radiation, and this is her postoperative exam. We scooped out tumor from around the right paraclival carotid. This is essentially mucosalized clival dura here. Looking at the sella, subtle pulsations that may be appreciated through that area. Key things to keep in mind when you see inverted papilloma, the overall rate of recurrence now with the endoscopic techniques is probably around 10%, but I don't think it's fair to quote 10% for all comers. When we have tumors that were in one of my former residents, Stephen Kennedy, who's now at Penn, really helped us understand this. When you look at tumors that are limited to the nasal cavity, ethmoid, or the medial maxillary wall, and this is a pooled study of almost 2,000 patients looking at all the cases reported in the literature at that point in time, we actually do pretty good, about 3%. But any other wall of the maxillary sinus other than the medial wall, frontal or sphenoid, risk of recurrence, endoscopic techniques, it's actually quite a bit higher. It's about 20%, and anything that's beyond the sinuses, the risk even goes up to 33%. So depending on the location, I think it's more honest to quote this in somewhat of a more graduated, incremental, higher risk. So these are the lessons learned. I treat these no differently than malignancy in the sense that I want to get this to negative margins. No question, most of the cases I get sent are recurrent or residual IP, and they likely have a higher risk of recurrence. There's nothing wrong with open approaches with these cases. In fact, many times I think it's very appropriate to use them. You just have to be thoughtful about when they're needed. And really your first time is your best time to get these out. But some cases with extensive sphenoid or frontal tumors, there should be consideration for staging. If there's squamous cell carcinoma, unless it's a microfocus, if it's grossly invasive squamous cell carcinoma, I really don't care about the IP at that point in time. I've had 2 patients die from squamous cell carcinoma arising in IP. I treat it no differently than squamous cell carcinoma. My point being, don't undertreat them or don't let your guard down because it's IP with squamous cell carcinoma. Shouldn't be treated any differently. And I follow these patients forever. I've seen cases sent to me that recurred after more than a decade. They can recur. They can have malignancy that can arise after the tumor's been gone for a decade. And there's great data out of UK that shows that. So once you operate on them, tell them they ought to be followed forever. Fibroosseous tumors, you will see a whole host of lesions, and I have now, biopsied things that I won't have to biopsy again. I've learned from my experience. So I want to just show you some of these, and we wrote a paper on it, and it wasn't that I was just looking to create cases, but it takes time to understand who you ought to biopsy and who you shouldn't biopsy. I certainly did not biopsy these cases. This patient never even had surgery. So compact ivory osteoma, here's another one. Fibrous dysplasia, this is more the classic ground glass appearance. If this sits around for years and years or decades, it gets this kind of this cotton wool appearance. Doesn't need biopsy either, but does need biopsy and aggressive resection or ossifying fibromas, and these can be difficult diagnoses to make just on radiographic imaging, but you can see this component of fibrous and osseous tumor with a bony margin that's expanding. A couple of other unusual lesions, eccridosis falciparum, typically arises at the level of the clivus. If you have an astute radiologist who can find this for you and point it out, this does not need a biopsy. And then this is osteoradionecrosis of the skull base after previous radiation for nasopharyngeal cancer. Another lesion is arrested pneumatization. Again, if you know these things, you can look them up, you can save the patient an operative procedure. And this is our data. We looked at 60 lesions and we correlated. These are not just all my cases, these were just all cases taken care of at Southwestern over a number of years. And what we found is that when you looked at the predictive value of radiology, we did pretty darn well for osteomas and fibrous dysplasia. When we suspected ossifying fibroma, we just didn't do as well. And so those are the types of cases where a biopsy may be indicated, but the reality is that most of these lesions can be observed. These are a couple of patients I have operated on. Frontal osteoma with a post-obstructive mucocele. This lady developed a periorbital cellulitis when she was attending a wedding in San Diego. She's from Texas, and I took care of her a few years ago and just showing you drilling of the posterior table of this osteoma. This is strictly all done through the nose. There was no external osteoplastic flap. A variant of osteoma, osteoblastoma, very aggressive lesion. This was actually pulling the midface forward. This was, again, a staged case because of the massive nature of this tumor. And again, this was all done through the nose. I left a little bit of tumor at the skull base after a massive tumor operation of probably a 13 or 14 centimeter tumor, and came back and staged the last little bit of component. I thought it was safer. And this is this child at about 3 years. This was a 12 or 13-year-old kid. A little bit of edema along the orbit, but overall a very functional result. Angiofibromas, most of these now can be managed endoscopically, just showing you an extensive Radkowski stage 3A, involvement of the pterygoids, infratemporal fossa. My experience is that these tumors tend to be very fibrous, and majority of them can be taken out through the nose. I have not had to make any accessory incisions for these types of tumors. This is what your cavity looks like, and this is this young man at 2 years follow-up. One of the humbling things I've learned about JNAs, it takes forever for these things to heal. they get massive edema, they get polyps. There's so much disruption of the anatomy that the healing in these young patients is an incredible challenge. So I think close collaboration with IR is really critical. I will not take them to the OR until I've had that call from IR and I've had a chance to really review it. And really understanding the patterns of spread. And you can really, these tumors can be massive, but if you can take them out compartment by compartment, it really, the surgery goes much better. And the last thing to keep in mind, if there's tumor extension along the Vidian canal, that always ought to be drilled. There's nice data by Valerie Lund showing that this can help decrease the risk of recurrence. And then pituitary tumors as well. We did a prosection of this, just showing you a non-functioning adenoma and the end result intraoperatively at the time of surgery. You can see the illumination and the magnification of the telescope allows you to really look at the interdural compartment, looking at the descent of the arachnoid to make sure that it's symmetric, and using angle scopes to look around the corner. There's several meta-analyses now which will attest to the efficacy of the endoscopic approach over the sublabial transeptal approach. These are just my lessons on minimally invasive pituitary surgery. Really careful preoperative review of imaging. I use topical epi only, even when I raise the nasal septal flap, and I've found the hemostasis to be just adequate. And then typically I'll expose the cellular dura and then I transition, but I do not leave the room. I may have a resident who's holding the scope for them, but you are really beholden to the skill of your neurosurgeon here. Access is not that hard, but if you get into cavernous bleeding or if you have a massive high flow leak, you got to be able to deal with those things. And if you're not sure that your neurosurgical colleague can tackle those things with you, then this may not be the right surgery. So it's not just about the access, it's critical. The critical aspects are tumor removal and then managing high flow leaks. I have now, this past year, managed 2 high flow CSF leaks sent in after cellular surgery on the outside. Both patients presented with massive pneumocephalus similar to what Chris showed, and those can actually be very difficult to fix once they form mature tracts coming through the arachnoid through the third ventricle. And now I'll just move on and talk for the last few minutes about sinonasal malignancy. This is clearly the most humbling aspect of what I do. I start with this gentleman who presents with really headaches and mental status changes. His wife thought he was acting goofy and took him to the PCP. This led to lots of imaging, and then he has this massive tumor. What you're seeing here is brain invasion and massive, vasogenic edema of both of the frontal lobes from this tumor. And this is his scan after chemoradiation. The tumor completely melted away. He never needed any sort of surgery. But 6 months later, he's a home builder, he's back at work, and then he tried to get out of bed and literally fell out of bed because he did not have any motor function of his lower extremities, developed cauda equina syndrome related to just a diffuse leptomeningeal metastases from this tumor, and then had a very progressive, quick decline, unfortunately. But my only role there was a biopsy. I don't think I could have cured this with open or endoscopic surgery. So these are challenges. These are big tumors, difficult access regardless of the approach you want to take. Then all the proximity to critical structures really raises the bar of surgery. This is all based on the initial work by Ketchum, where they looked at 19 patients and were able to achieve disease-free status in 9 of these, ranging anywhere from 2 to 75 months. And this open craniofacial resection was really the workhorse since the 50s and 60s. And so this combines a transfacial approach, whether it's a lateral rhinotomy, mid-face degloving, combined with either a bifrontal or subfrontal craniotomy, and really has been the workhorse of management of these tumors. But when you start to look at large reviews of these cases, you can see the perioperative mortality of these cases, depending on what study you look at, can range up to 13%, and postoperative complications do happen in most of these cases, frankly, but it can range anywhere from 1/3 to 2/3 of the patients, and it can be in the form of whether it's wound infections, hemorrhage, orbital problems, and all the other things that we talked about earlier. So with the endoscopic paradigm, we're using now the rigid endoscope as the primary surgical modality. Again, we can address the sinuses, we can address the orbital interface, we can go to the skull base, we can take down the cribriform plate or ethmoid roof complex, we can take down the dura, we can go a layer beyond, we can take down the olfactory bulbs. If you're having to resect brain, this may not be the right patient that you're operating on. But again, I think there has to be some careful selection of cases there. And you can still add a bifrontal craniotomy if needed. I present all these cases that are tumor board. You can't manage these any differently than our head and neck surgical colleagues. I think that's critical. You have to be part of the tumor team. You have to know the radiation folks. You got to know the medical oncology folks. You have to know the tumor staging and all the things that we expect out of our head and neck colleagues. And then really developing consensus on what is the best approach for the patient. It's not about the endoscope. It's not about the open approach. It's really what is best for the patient. And then also planning for open approaches as is indicated. There's no question that a large multi-center, a multidisciplinary approach is best. I think you really need great expertise in all of these areas, not just 3 or 4, if you're really going to drive the best possible care for these patients. And your oncologic goals with the endoscope do not change. It's still negative margins, but try to figure that out if you can balance that with their quality of life, neurologic function, all the things that we as human beings care about, whether it's their physical appearance or voice or vision, and at the same time striving to minimize complications. And these are the variety of different approaches, and on any given day, depending on the complexity of the tumor, we may be using any or all of these, and these cases are taxing. The shortest one may be 4 hours, but some of the longest cases may be 10, 12, 14, or 20 hours. It just depends. And really the key surgical strategy is you have to identify all the sites of tumor attachment. You can have a massive nasal tumor, but if it's just pedicled on a little site, it doesn't matter how big that tumor is. Surgery is actually pretty easy. But then you'll have tumors that'll have 20 points of attachment all over, and that's very difficult. And those are cases where you may be doing 30, 40, or 50 intraoperative frozen sections. But the idea is whatever the point of attachment is, trying to resect that area en bloc if technically feasible. Not the whole tumor, the area of attachment. I think it's very difficult to get the whole thing out en bloc and then doing intraoperative frozen section control. This is minimally invasive endoscopic tumor surgery, but it's maximally invasive surgery. It's an oxymoron. We're just using the nose as an access point, but beyond the nasal dorsum and this caudal septum, everything else beyond that may be gone. There may be just a giant cavity. And that is the type of aggressive surgery you have to strive to achieve for these aggressive malignancies. So this is not endoscopic sinus surgery. This is not FACS. So this is a patient I took care of many, many years ago. So the video, this is standard definition, so not as quite as nice, but had sent to me with the idea of a sinonasal chordoma, which doesn't really make sense. Chordomas arise in the clivus. So we had this we had the pathology reread. This is back when I was at the Cleveland Clinic, and this actually turned out to be a clear cell carcinoma. And this is resection of this, getting margins laterally, and then resection of the cribriform plate complex en bloc, and cutting all the olfactory phyla, and then doing biopsies. And this is her result. I moved to Texas. She came to see me a few times there. She still has my email. She's now, actually, this is her imaging at 5 years, but I think she's now about 7 years out. And just showing you what the postoperative result looks like. You can see there's nothing left inside that nose. But take a look at her mucosa. This is not an empty nose syndrome. There's no ozena here. They actually heal just fine. And she's had radiation too. But I can also tell you I have lots of patients who have ongoing issues with crusting. They don't always heal like this. But the reality is they can get to this. Neurosurgery has a critical role in these cases. I consider them as co-surgeons. I think it's important that you have a great neurosurgical partner. And then for the endoscopic skull-based work, either I'm assisting them or they're assisting me. But we like to try to get 3 hands in there as much as possible. I'm comfortable doing work to the dura. I'll do limited dural resection. if we're really doing transdural work, I work in a very high malpractice state, and I think you really have to question, where does her skill set, despite her technical abilities, what does your board certification allow, and when should that really be handled by the person who really is the designee of managing the dura, taking out the olfactory bulbs? And I think I know colleagues that will take out olfactory bulbs, but I also don't know if that's the best way to build the collaboration and the team. So this is my colleague, Sam Barnett, who was at Southwestern, and this is him working while we're holding the scope for him. I had removed the entire tumor up to the dura, and then he resected the dura, and he took out the left olfactory bulb. And this is the lady who had this T4B. This was followed by N0 olfactory neuroblastoma. This is her postoperative results. You can see a little bit of subtle crusting that still persists, but overall a reasonable result in this patient. There's no question that the nasoseptal flap is an important component of what we do. But I have to tell you, I take care of lots of these tumors where there's nothing left in the nose. What do you do? This is great to talk about for cellular surgery, for clival tumors, but for a lot of sinonasal malignancies, there's nothing left in the nose. And I think that in those cases, you can have multi-layered reconstruction, and yes, it can work, but I can also tell you from personal experience that patients that get orbit-to-orbit dural resection, planum to the posterior table of the frontal sinus, they are at higher risk for pneumocephalus and higher risk for recurrent postoperative leaks. There's no question about that, especially if it's done in the setting of previous radiation. I think the healing can be an incredible challenge. This is a case that we did about 3 years ago. You can see this is a sarcoma, and this gentleman had presented with nasal obstruction and headaches. You can see there's a intracranial knuckle of tumor that's essentially traveling along the olfactory phyla, and this tumor was all resected endoscopically. Again, my neurosurgical colleague took out that knuckle of tumor endoscopically, and he is, I didn't put a time on there, but this is about 3 years out now, and I do have post-op imaging on him as well. But the point of this was to show you what that nasal septal flap in that cavity looks like post-op. You can see the nasal septal flap looks essentially the same as it did at the time of surgery, some stenosis of the frontal in that case. For the sake of time, I'm going to have to, unfortunately, run through some of the data. This is an hour-long talk, and I tried to squeeze as much as I could into 30 minutes for you. But this is really the data that we have to use to compare our endoscopic results. And this is the international collaborative study. This is an open craniofacial resection. This is an international database of these tumors. And you can see that if you look at the actuarial survival, 5-year disease-specific survival, 60%, 5-year overall survival, 54%. So about half of these patients that I meet, they're no longer alive at that 5-year mark. And I don't know if we've changed that necessarily with the endoscope, but we have changed is the way they live after that operation. There's no question that's now drastically different. When I worked with Don and Martin at the Cleveland Clinic and Jung Lee, our neurosurgical colleague, we wrote some of this early data, not a large series, but 10 years ago, most people were not talking about these things. I have to give a lot of credit to Don, that he was really one of the early proponents and really the innovator of many of the things that I'm talking about here. But the data showed that the outcomes, the intraoperative parameters were fairly comparable. This is data by Roy Castellano, essentially showing the same thing and actually showing that the OR time, hospital stay, ICU stay was actually better. We've had multiple other studies published from our work in Cleveland and also Southwestern. I'm going to skip through these for the sake of time. The largest study to date has been by Piero Nicolai's group, published several years ago, 184 cases, and really showing incredible results where you can see 5-year disease-specific survival, 91.4% and 58.8% for the more advanced, higher stage malignancies. We're doing a fair bit of work now on the quality of life of these patients as well. We've published 2 papers, and we have a third one that's currently under consideration. And what we find is that for these malignant cases, their overall SNOT-20 scores really actually don't change very much. They don't get worse, but they don't get a lot of better. They don't get better either. And we have now data that's under consideration for patients with SNOT-20 data that's more than 2 years out. Interestingly, smoking and prior chemoradiation are independent negative predictors of worse SNOT-20 scores. So if I may, can I have 1 or 2 more minutes? Would that be okay? 1 minute, okay. Otherwise, he's going to bring out the gong. I'm going to go fast here, Greg. So these are the lessons learned. I think you really have to individualize the treatment plan. It can't be the same thing for every patient. It can't be, I'll take out what I can with the endoscope and then dump them on the radiation and medical oncologist and let them figure it out. I think you really have to be the active participant. I think chemotherapy has been historically underutilized for this disease. As a patient with a basaloid squamous cell carcinoma that I saw, and he did not want surgery, elected for chemoradiation. I thought I would never see him again. This was almost 10 years ago, and he came back to see me. This was his postoperative scan, a little bit of signal enhancement. The entire tumor disappeared. Remember, there are limitations. Certainly bilateral massive disease or vascular tumors. These are not contraindications, but I think these are not cases that I would take on in the first year in clinical practice. But I think if there's massive brain involvement, massive involvement of facial tissues, or this patient who had a small cell carcinoma of the sinuses with diffuse metastases everywhere, these are not good cases for oncologic control or what we would consider curative resection. I do open surgery as well. This is one of my cases, so it's not that you can do the endoscope, but then it's something else, then you just pass this off to somebody else because you're not comfortable. I think that you have to be able to tackle these sort of cases. Squamous cell carcinoma invading into the orbit has already failed 2 previous surgeries, chemoradiation. I stopped there. That's me. This is a neurosurgeon. That's Duracell on the dura and free flap, and that's him looking back post-op day 1 in the ICU, and he's 1 year out. Not a pretty result, but he's happy to be alive, and that's got to count for something. So this has been the experience. I've been fortunate to work with great colleagues, starting with Don and Martin, and great neurosurgeons at the Cleveland Clinic, Southwestern, and now at Rush. And these are just the numbers. I've always kept track of these cases. So these are the benign histologies on the left side and the malignant histologies. And these are the cases that it's resulted in. About 340 tumor resections that are for curative intent, but also additional things, patients that just needed biopsies, open craniofacial resection, palliative resections, maxillectomies, et cetera. I did not count CSF leaks. I just put the number up there, but that's not really counted in the actual, I think our data still suffers. I don't want to paint a rosy picture. I think this is the most difficult part of what I do. The surgery can be interesting, but having to tell somebody they've recurred. I just saw a young gal that I operated on about a little over a year ago with a rhabdomyosarcoma, and she's now got new lesions in her lung, but her primary site is completely clear of disease. And to have to talk to her and her father sitting there will be the hardest thing that we do. So, I think it's important to remember this is not glamorous surgery, but if you want to take care of these sort of difficult patients, I think it can be gratifying and frankly humbling too. I'll end with that. I want to thank you again for the invitation.